Good afternoon, dear medics. I'm Dr. Anye Marion, and you're welcome to Healthy Everyday. In this channel, we learn more about medicine. We learn about how to stay healthy, both physically, mentally, emotionally. So today, we are going to be talking about hypertension, which is a very common disease in our society here in Africa. But before that, I'll start by apologizing for the first video which did not reveal my face. As you can see, this is me, Dr. Anye, and let's move straight into business. This presentation is supervised by Dr. Amadu Jigi and Professor Ashutang Gloria. At the end of this lecture, we should be able to define what hypertension is all about, list some etiologies of hypertension, list the minimal workup and expected findings in a patient presenting with hypertension, list the principles of management, list the treatment strategies of complicated and uncomplicated hypertension. Let's dive straight into it. This is our course outline, definition, epidemiology, and after that we're going to classify hypertension, give some diagnostic evaluations, and then list some complications. Hypertension is defined as an office systolic blood pressure of greater than or equal to 100 millimeters of mercury and or a diastolic blood pressure of greater than or equal to 90 millimeters of mercury. This is the classical definition of hypertension. It has a lot of scientific terms. Okay, to better understand what hypertension is, imagine water flowing through a pipe. The force with which the water flows through the pipe is the pressure of the water in the pipe. So take our blood vessel, for instance, and compare it to that pipe. The force with which the blood flows through the blood vessel is the pressure of the blood flowing through the blood vessel. So hypertension occurs when the pressure, the force with which the blood flows through the blood vessels is higher than 140 divided by 90 millimeters of mercury. So these are the determinants of blood pressure. Blood pressure equals to stroke volume multiplied by the heart rate multiplied by the peripheral vascular resistance. The stroke volume is the amount of blood ejected from the heart with one beat. The heart rate is the number of beats the heart is the number of cycles in 1 minute, is the number of times the heart beats in 1 minute, and the peripheral vascular resistance is the resistance to blood flow through the blood vessels. So the larger the blood vessels, the lower the peripheral, or let's say the larger the canal of the blood vessels, the lower the peripheral vascular resistance. So if there's an increase in the stroke volume, the amount of blood that the heart ejects with one beat, and there's an increase in the heart rate, and or there's an increase in the peripheral vascular resistance, like in case of vasoconstriction, there is going to be an increase in blood pressure. Think for a second and see some conditions that lead to increase in stroke volume, increase in heart rate, and increase in peripheral vascular resistance. And with that, you are going to understand the causes of hypertension. Hypertension is a major risk factor of cardiovascular disease, and as we said from the beginning, it's very prevalent. It affects 1 billion adult individuals globally, and in Cameroon here, the prevalence is about 30%. That means that about 30% of all adults has hypertension. More than 7 million deaths per year are attributed to hypertension, which means the mortality is also very high. Hence, they need to know more about this disease. This disease is either underdiagnosed or undertreated in low-income countries such as Cameroon. So this is the classification of hypertension according to the European Society of Cardiology. The optimal blood pressure should be less than 120 or less than 80. As you can see, Hypertension starts with grade 1, greater than 140, and grade 2 when the blood pressure passes 160, the systolic blood pressure to be precise, or the diastolic blood pressure surpasses 100, is greater than 100, and grade 3 when the systolic blood pressure is greater than or equal to 180. Isolated systolic or isolated diastolic blood pressure is when the systolic blood pressure is high. For isolated systolic blood pressure, the systolic blood pressure is high and the diastolic blood pressure is normal. For isolated diastolic blood pressure, the diastolic blood pressure is high and the systolic blood pressure is normal. Clinical presentation in a patient with hypertension. Most patients with hypertension are asymptomatic, especially those in grade 1. But when symptoms occur, the primary symptoms are headache, tinnitus. Tinnitus is like ringing sensation in the ear, ringing sensations. You can hear something like wee 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 in your ear. That's tinnitus. Dizziness or lightheadedness. You stand and you don't see clearly, or you can have vertigo, like you see places are turning around you. Epistaxis is nose bleeding. Paresthesias is tingling sensations around your body, like you feel as if ants is moving on your legs, on your hands, and others. Dyspnea is difficulties in breathing. Okay, let's dive straight to the etiologies of blood pressure so that next time you see a patient with hypertension, you know what could be the possible causes. Causes of hypertension. Hypertension could either be primary hypertension or secondary. For the secondary etiologies of hypertension, it means there is something causing the hypertension. For secondary, it means there is a disease that causes the hypertension. For example, we have renal parenchyma disease such as glomerulonephritis, polycystic kidney disease, reninomas. Reninomas are benign tumors of the kidney. Lead nephropathy, like excessive consumption of lead or excessive lead in the blood can lead to kidney disease. Reflux nephropathy, this is in case of an obstruction to the urinary tract leading to reflux of urine back to the kidneys. It's called hydronephrosis, in other words. So it can lead to kidney disease and subsequently hypertension. So renal parenchyma disease contributes to about 2 to 3% of hypertension. The next, we have renovascular disease such as atherosclerotic disease like renal thrombosis, renal stenosis can lead to decreased blood flow to the kidney and hence tubular necrosis, which can lead to hypertension. Fibromuscular dysplasia and polyarteritis nodosa. Polyarteritis nodosa is an autoimmune disease. Okay, sorry for the interruption. We're talking about hormones, and we said hormones were substances made up of proteins secreted by some glands that we call endocrine glands. These hormones enter the blood and go and have effect on target organs. Okay, some disorders of these endocrine glands, to be precise, can lead to hypertension, secondary hypertension. Pheochromocytoma, this is a benign tumor. Yes, it's a benign tumor of the adrenal medulla and other neuroendocrine tissues, and can lead to excessive production of mineralocorticoids, leading to excessive water retention into the blood vessels. If there's an increase in the volume of blood in the blood vessels, there's going to be an increase in the blood pressure, of course. Like using our example of the water in the pipe, if there is much water, I mean really much water flowing through a pipe, the pressure is going to be high, of course. So if there is much blood flowing through the blood vessels of the body, the blood pressure is also going to be high. Primary hyperaldosteronism. Aldosterone is a mineralocorticoid, so it's going to lead to increase in water retention and into the blood, leading to hypertension. Cushing syndrome. This one is a side effect of glucocorticoids. Hyperglucocorticoids means hypersecretion of cortisol, probably from a tumor in the adrenal gland. This hypersecretion of cortisol just increases the metabolism of the body, increases everything in the body, increases glucose, increases fat metabolism, changing it to glucose, increasing glucose intolerance, it just increases everything, and also increases water retention, leading to hypertension. Thyroid, thyroid function, hyper and hypothyroidism. All of this can lead to hypertension. Parathyroid disease also, acromegaly is excessive growth hormone in adults, leading to growth of the short bones in adults. This can also lead to hypertension. Okay, other secondary causes such as drugs like cocaine, amphetamines, cyclosporine, clonidine withdrawal, sympathomimetic, steroids, and non-steroidal anti-inflammatories. All of this can lead to hypertension. We are going to go through each of these things in details in subsequent videos. Secondary hypertension. We can also have a vascular cause known as coarctation of the aorta. Aortic coarctation is a congenital disorder in which there is a narrowing of a portion of the aorta, predominantly the thoracic aorta. That narrowing leads to a reduction in the blood vessel, a reduction in the lumen of the aorta at that particular region. So, so there's a resistance to the flow of blood in that particular region. So there's as let me put it simply, there is narrowing of that blood vessel, that is the aorta. There is narrowing of the aorta, leading to increase in peripheral vascular resistance. From our equation, we knew that blood pressure was equal to stroke volume times heart rate times peripheral vascular resistance. So if there is an increase in the peripheral vascular resistance, what happens to the blood pressure? The blood pressure is going to increase. So the narrowing of the aorta leads to an increase in the resistance in that aorta, leading to an increase in the blood pressure. Preeclampsia, these are conditions in gestation where there is an increase in blood pressure due to poor penetration of the placenta into the mother's circulatory system, and to compensate for low delivery of food and oxygen supplies to the baby, the mother has to pump more blood with the higher pressure, leading to hypertension. Obstructive sleep apnea is a situation where there is an obstruction in the airway at sleep. Either there is hyper relaxation of the airway leading to an obstruction. Is in fact, in common terms, is what we call snoring. So there's less delivery of oxygen to the blood, and when there's less delivery of oxygen to the blood, to compensate for the less oxygen being delivered to the tissues at the peripheries, the heart is going to pump blood faster and more powerfully. So there's going to be increase in the contractility, there's going to be increase in the heart rate at sleep, leading to an increase in blood pressure. So these are some clinical clues you can use to know the exact cause of a secondary hypertension. For polycystic kidney disease, you're going to be wanting to palpate and enlarge kidneys. For coarctation of the aorta, there's going to be a radiofemoral delay, like when you are palpating the radial pulse and the femoral pulse, you're going to see that it's not in sync, there's a delay. For renal artery stenosis, there's going to be paraumbilical murmurs. For Cushing syndrome, we're going to be looking at Cushingoid appearance. We're going to dive into Cushingoid appearance when we're going to be studying Cushing syndrome. The second type of hypertension is what we call primary or essential hypertension, which is the most common cause of hypertension in adults. 90 to 95% of cases of hypertension is primary hypertension, and this results from the interaction between gene, lifestyle, and environmental factors. So the risk factor to developing this type of hypertension is older age, that's greater than 35 years, and after 50 years, the lifetime risk becomes about 90%. Diet, high salt intake, high fat intake can lead to hypertension. Physical inactivity, that's sedentary lifestyle, you don't do sports, you don't trek, you just sedentary lifestyle. Then there is obesity, there's excessive alcohol consumption, there is a family history, that is if your parents had hypertension, there is a risk for you to have hypertension, especially if you have a reckless lifestyle, like you eat a lot of salt, you drink a lot of alcohol. Then there is smoking. Also, Africans are more at risk of having this type of hypertension. Males have a greater risk than females. Stress, like chronic job stress, you go to work, you're not comfortable, you're stressed out. And then there's also diabetes mellitus. So there's an interaction between gene, environment, and lifestyle. The gene is, let's just say, the family history. Then when it interacts with the lifestyle of poor diet such as high salt intake or high fat intake, physical inactivity, obesity, excessive alcohol, and smoking, it can lead to hypertension, even chronic job stress. So these are things that we have to avoid in order to live a healthy life. So these are some arguments for secondary hypertension. If a patient comes presenting with a very high blood pressure of greater than 180 or greater than 100, we should first start by suspecting secondary hypertension. We should look for a secondary cause. If there are complications at the time of diagnosis, we should also look for a secondary cause. And then if the patient is less than 35 years at time of diagnosis, we should also look for a secondary cause. Diagnostic, diagnostic evaluation. We have to confirm the diagnosis of hypertension, to identify secondary causes, to assess the presence and the absence of hypertension-mediated target organ damage, and to assess lifestyle and identify other cardiovascular risk factors or concomitant disorders. Identifiable causes of secondary hypertension. These are some clues. We already mentioned them. We look for features of Cushing syndrome, and then for pheochromocytoma, we look for neurofibromatosis. We look for some tumors on the skin, some nodules on the skin. If you palpate an enlarged kidney, we think more of polycystic kidney disease. Auscultation of a heart murmur, renovascular hypertension. Auscultation of an abdominal murmur. In fact, yes, we can have renal stenosis that can cause hypertension. That's renovascular hypertension. Auscultation of precordial chest murmur. We can have aortic coarctation, aortic disease, upper extremity artery disease. Diminish or delay femoral pulses. We can also think of aortic coarctation. Left and right arm blood pressure differences. We can think of aortic coarctation. So these are some clues for us to think of secondary hypertension. Some causes of secondary hypertension: we have chronic kidney disease, we estimate the glomerular filtration rate. We have aortic coarctation, the investigation, we can do a CT scan, angiography. Cushing syndrome, obviously, we can do dexamethasone suppression tests. All these things, we're going to dive deeper into it while studying each of these conditions in detail. You can just screenshot this slide to read it a different time. So to assess hypertension mediated target organ damage, we are going to do the creatinine. The serum creatinine is used to check the kidney function because it's usually eliminated by the kidney. If there's an elevated serum creatinine, it means that the kidneys are becoming damaged. And this creatinine can be used to estimate the glomerular filtration rate, which is the amount of blood being filtered in the kidney in 1 minute. Electrocardiogram is used to check the heart function. You can check and see left ventricular hypertrophy and O myocardial infarction. Fundoscopy is for hypertensive retinopathy. Hypertension can lead to ruptures of the tiny blood vessels that are found in the retina supplying the eye. So if these blood vessels become sclerotic and some might even rupture, this can cause disturbance in vision. We can have stroke. Hypertension can lead to stroke. Stroke is a complication of hypertension. So we're going to be testing for motor and sensory defect. To check the retina, we're going to do the fundoscopy. You can just screenshot this slide and read it for better understanding. When a patient comes presenting with hypertension, there are some things we have to do. We have to take the medical history, a history of coronary artery disease in the patient. Things like angina pectoris, like chest pain, dyspnea, that's difficulties in breathing, and also a family history of stroke, a family history of heart disease, a history of heart failure, stroke, chronic kidney disease, and diabetes mellitus. And laboratory investigation, it's a routine. We have to do the lipid profile of this patient. That's the total cholesterol, the low density lipoprotein cholesterol, the high density lipoprotein cholesterol, and the fasting triglyceride. We're also supposed to do the fasting blood glucose to rule out diabetes in such patients because all of these have cardiovascular risk factors, and these are risk factors of hypertension. Okay, routine diagnostic workup. The ECG might reveal left ventricular hypertrophy. This is the classical finding in patients with hypertension. Because let's use this small illustration. If there is high pressure in the aorta, like the pressure in the aorta is ridiculously high, that is hypertension. The left ventricle is going to need more force to pump blood against that pressure in order to supply blood to the entire body. So what does the left ventricle do in order to have that power? It increases in size. That's what we call left ventricular hypertrophy. Urinalysis might reveal proteinuria and hematuria, like in case of secondary hypertension. Secondary hypertension due to a glomerulonephritis can reveal proteinuria and hematuria. Blood glucose might reveal diabetes mellitus. Hematocrit, polycythemia, serum potassium, hypokalemia, and primary hyperaldosteronism. Like we said, primary hyperaldosteronism is going to lead to increased water retention in the blood, and there's going to be an increase in the volume of the blood that is in the blood vessel, leading to an increase in the blood pressure. Creatinine, that's in case of kidney failure. High density lipoprotein cholesterol, low density lipoprotein cholesterol, and triglycerides. That's in general dyslipidemia. These are all risk factors of hypertension. Fundoscopy might reveal hypertensive retinopathy. So, what are the complications of hypertension? Complications of hypertension can be multi-system. Yes, we have multi-system complications of hypertension. So, for the cardiovascular system, there's, there's complications on the heart, there's complications on the blood vessels. Then we have complications on the kidneys, complications at the level of the brain, complications at the level of the eye. Complications at the level of the heart, we have left ventricular hypertrophy, we have heart failure. At the level of the blood vessels, we have atherosclerosis, we have sclerosis of the blood vessels. At the level of the kidneys, we can have hypertensive nephropathy. Things like an increase in blood pressure can lead to nephrotic syndrome. In the brain, we can have stroke, and in the level of the eyes, we have hypertensive retinopathy. So these complications are as thus: hypertension increases the risk of stroke by up to 5 times. So this is a very dangerous disease. We should be very careful. We should be very careful. Can increase the risk of you having stroke by up to 5 times, the risk of you having heart failure by up to 3 times, peripheral artery disease by up to 3 times, and coronary artery disease by up to 2 times. So we should be very careful with this disease. We should learn the preventive measures and take care of ourselves in order to live a healthy life. So cardiovascular complications include left ventricular hypertrophy, like we said, heart failure, coronary artery disease, arrhythmias, and ventricle. That's arrhythmias. We can have atrial arrhythmias and ventricular arrhythmias. We're going to dive into it when we're going to be talking about these things in specific in another video. Peripheral artery disease and aortic aneurysm. Cerebrovascular complications. We have stroke, like we're saying, complication in the brain. Stroke can lead to stroke. It can lead to transient ischemic attack and vascular dementia. Renal complications, we said it can lead to nephrotic syndrome and chronic kidney disease. This chronic kidney disease. And ocular complications, we have hypertensive retinopathy, which can decrease your visual acuity, so it can lead to visual disturbances. So this is the global cardiovascular risks. Those with the deep red, you can see they are at high risk, and they have higher rates of having more complications than those with yellow and the others, and orange. So each time you take your blood pressure, and your history, you can come to this chart and come and check if you fall under a high risk or you fall under a low risk. If you're under a high risk, you need treatment and you need to modify your lifestyle based on what we have been talking throughout. If you're under low risk, you just need lifestyle modification, continue to live healthy, do your regular exercise, eat more fibers, stop salt, don't eat a lot of salt, reduce the salt intake, reduce fatty food intake, and reduce alcohol intake, and stop smoking. So the management of hypertension is as does, and it's easy, it's not difficult to memorize. The goals, we have to understand the goals. We have to reduce the blood pressure below 140 or 90 for all hypertensive patients. If this patient is a diabetic or this patient has renal failure, the target changes to below 130 on 80. And if this patient is greater than 70 years, the systolic blood pressure must go below 150. And also, we have to correct all risk factors and prevent and treat target organ lesions. To correct all risk factors, this include the modifiable and the non-modifiable. We have to correct them. The non-modifiable, we cannot correct them, but the modifiable, things such as diabetes, alcohol intake, smoking, excessive salt intake, we can correct those things. So physical exercise, yes, those are things we can correct. So we're going to start with non-pharmacological management. Like we were saying, we have to reduce our salt intake. I will not emphasize more on this. Reduce salt intake below 5 grams daily. Lose weight. Lose weight. Every kilogram of weight of mass that you lose can reduce your blood pressure by 1 millimeter mercury. Lose weight. Reduce alcohol intake. Reduce alcohol intake. Alcohol is a devil. Don't take alcohol. Alcohol can cause you insulin resistance and lead to weight gain, leading to hypertension, leading to diabetes, leading to polyphagia, which leads you to eat unsaturated fats, leading to more insulin resistance in a vicious cycle in which you just gain weight, have hypertension, and have diabetes, and it keeps adding in a vicious positive feedback. Stop alcohol. Alcohol is a devil. In fact, stop it. Regular physical exercise. Regular physical exercise, we already talked about it. We also have to correct associated risk factors such as we have to stop tobacco smoking and we have to increase our food intake and vegetables. We need to reduce the intake of animal fats. Saturated fats can lead to insulin resistance, leading to sclerosis of the blood vessels. We have to reduce our saturated fats and treat diabetes or glucose intolerance because this is a positive feedback. They are hand in hand. Hypertension stand for this side, diabetes stand for this side. Yes, they just the join so for positive feedback, just the menance about it. We have to treat these things. Okay, pharmacological management. Their main class of drug when to initiate treatment of uncomplicated hypertension, treatment of complicated hypertension, and treatment in particular patients, and also management of hypertensive emergencies. The principle, you have to personalize the treatment. The treatment is different for every patient. Socioeconomic evaluation for the patient, and we have to create a lifelong treatment plan because this treatment is not going to be stopped. It's a lifelong treatment. You have to manage the blood pressure so that it does not increases. So monotherapy is the goal. Monotherapy, we don't need the patient to be on a lot of antihypertensive medication. So we want monotherapy. Even if we increase to bi and triple therapy, we want to eventually control the blood pressure with 1 BP medication. So these are the major classes of drug. We have diuretics. Diuretics, e.g., like thiazide diuretics, such as hydrochlorothiazide and idapamide. This leads to water excretion at the level of the distal convoluted tubules, reducing water and sodium in the blood. And if there's a reduction of water and sodium in the blood, there's a reduction of the blood volume, leading to a reduction in blood pressure. We have calcium channel blockers. For cardiac muscles to contract, calcium has to enter the muscle cells. As calcium has to enter the muscle cells for it to contract, if you be block calcium from entering the muscle cells, the cardiac muscle is not going to contract. This is going to reduce what we call the contractility, which is going to reduce the stroke volume. It's going to reduce the peripheral vascular resistance, leading to what? A reduction in blood pressure. Easy, not difficult. Beta blocker, this is what stimulates the heart to beat now. Yes, the beta receptors. So example of beta blocker, we have atenolol and bisoprolol. This one work by reducing the heart rate. You reduce the heart rate. If you reduce the heart rate, what do you do? You reduce the blood pressure. Angiotensin converting enzyme inhibitor. They work on the angiotensin converting enzyme and preventing the formation of angiotensin 2. What does angiotensin 2 do? One, it increases vascular resistance. Two, it causes water retention from the kidneys. It leads to the secretion of aldosterone, which causes water retention from the kidneys. So if you block the production of angiotensin 2, there's going to be less water retention in the kidneys, leading to a lower blood pressure. Angiotensin receptor blockers has the same function as angiotensin converting enzyme inhibitors, but just lesser side effects. Others, we have alpha blockers. This one reduce alpha blockers. What are the alpha receptors for? To maintain the tone of the blood vessels. If you maintain the tone of the blood vessels, means they are increasing peripheral vascular resistance. But if you block alpha receptors, the blood vessels are going to be more relaxed and more how can I put it? The lumen are going to be larger, leading to a reduction in systemic vascular resistance and a reduction in the blood pressure. Central acting antihypertensive, and we also have diuretics. Some fixed combinations are there, like diuretics plus calcium channel blockers, diuretics plus ACE inhibitors, diuretics plus angiotensin receptor blockers. These combinations are in case one monotherapy does not work. So, okay, when to initiate treatment, a patient comes to you with high blood pressure. If the blood pressure is between 130 and 139, lifestyle advice, consider drug treatment for very high risk patients, like in patients with coronary artery disease and patients with cardiovascular diseases in general. Grade 1 hypertension, we have lifestyle advice. Grade 2 hypertension, from grade 2 hypertension, we need to start treatment, immediate drug therapy, because these patients are at risk of developing the complications of hypertension as listed above. Grade 3, immediate drug, we aim for control as soon as possible. Grade 3 hypertension is what they call hypertensive urgency. As soon as possible, we need the control in the blood pressure before we then take now a chronic plan. It's what we call hypertensive urgency if there is no end organ damage. But if there's an end organ damage, it's what we call hypertensive emergency. So, monotherapy, first line, low dose thiazide diuretics such as hydrochlorothiazide or idapamide. Long-term acting calcium channel blockers, amlodipine, nifedipine, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, beta blockers, and then these are some fixed combinations. Thiazide diuretics plus calcium channel blockers. In fact, just read them. You can take some time on this slide to read and see. This diagram here is an illustration of the combinations that are have been proven to work effectively. So you can look at it as well. So the treatment of complicated hypertension, like in case of angina pectoris, the drug of choice is we use a beta blocker plus a calcium channel blocker. In case of post-myocardial infection, we use ACE inhibitors plus beta blocker plus antidiuretic, anti-aldosterone such as aldosterone and aspirin. That's in case of myocardial infarction. In case of heart failure, we use ACE inhibitors, furosemide, anti-aldosterone, and beta blocker. ACE inhibitors and beta blockers are useful to increase the mortality in patients with, I mean, I used to decrease the mortality in patients with high blood pressure and heart failure, because these drugs inhibit cardiac remodeling. Yes, they stop cardiac remodeling, leading to a positive loop of hypertension, heart failure, hypertension, heart failure. In case of kidney disease, we use ACE inhibitor or angiotensin receptor blockers. This is to reduce proteinuria so that to slow down the progression of the kidney disease. And in case of stroke, we use aspirin, angiotensin converting enzyme inhibitors, and thiazide diuretics. The target in the acute phase of stroke, we need the blood pressure to go below 160 on 100 as soon as possible. In patients with diabetes plus proteinuria, obviously also we need ACE inhibitors because ACE inhibitor is to reduce proteinuria, and to reduce the proteinuria is also to reduce the progression of the kidney disease. Since diabetic patients are at risk of having kidney disease, so we're going to use ACE inhibitors or angiotensin receptor blockers. That's the same for patients with kidney disease. H equals to prudence. Calcium channel blocker or thiazide diuretics. Target systolic blood pressure should be less than 150. That is people older than 70 years old. Pregnancy equals to specialist advice. Pregnancy we use methyl labetalol and nifedipine. This is because these medications have less side effect in pregnant women and they don't cross the placenta nor they are not transferred to the baby during breastfeeding. Other medications such as ACE inhibitors, angiotensin receptor blockers, and diuretics are contraindicated because the baby is at risk. The baby is going to be at risk if you give these medications. So these are specific combinations. You can screenshot this slide to go through it on a different time. So follow up. You don't just manage a patient for hypertension and when the blood pressure is less than 140 or 90, you just allow the patient. You have to follow up. Drug treatment is indispensable. You follow up. Don't stop drug treatment if you have started. Auto BP control once monthly. Follow up is monthly. The patient should see you every month for BP control. And if you are the patient, go for your BP checkup every month. Clinical control every 6 months. This clinical control and biological control annually. These are very vital exams that you need to do. The issue is people often neglect this one. Biological control includes doing ultrasound, doing lipid profile, doing ultra natriuretic peptide to check the heart function, doing cardiac echography. Those are biological control. You have to do it annually to check how your body is functioning. This is for healthy living. After all, we are health and awareness now. Yes, healthy every day. Intermediate risks, that's for low risk patients. Patients with intermediate risk, mono or biotherapy. Obviously, we have to control the risk factor and we do control every 2 weeks. And we do clinical control every 3 months and biological control every after 6 months. For high risk patients, we need more than 2 medications to target the blood pressure and we have to control the risk factors as well. We need weekly control of blood pressure, clinical and biological control every 3 months. Prevention is, as we said, the modifiable factors you cannot control. The non-modifiable factors you cannot control. Your age, your sex, your race, your family history, you cannot control. But the modifiable factors such as diabetes, alcohol intake, smoking, excessive salt intake, sedentary lifestyle, that's physical inactivity, these are things you can control. What can you do to control it? Reduce your salt intake, do physical exercise, stop alcohol, stop smoking, stop eating saturated fats, stop eating animal fats, exercise, drink much water. These are things that you can do to prevent blood pressure. Thank you for watching this video till the end. I'm Dr. Anye Marion and this presentation was supervised by Dr. Amadou Jigi and Professor Ashu Tang Tang. See you next time. Don't forget to like the video and don't forget to subscribe to the channel. Thank you.